The PAOS is coming to Las Vegas this year. Our annual meeting is from September 1st through September 5th. This is an excellent opportunity to connect with other PAs throughout the orthopedic profession.
We have a great lineup this year with speakers coming from University of Nevada, Las Vegas, surgeons from local clinics, team surgeons from some of the local sports teams, such as Dr. Chad Hansen from the Las Vegas Raiders. We have a very comprehensive lineup. It's going to include anything from pediatrics, sports ortho, spine.
There will be poster presentations. There will be breakouts. There will be food. It's just a great time. Book your hotel room, book your flight, and make sure to register for the conference. Welcome to the orthoPAC podcast with your hosts Sam Dyer, Chuck Dowell, and Miles Gilbreth. Please join us as we attempt to fill in the gaps between education, current events, and real-world practice. Okay, thanks for that introduction from Chuck Dowell and Scott Jolman. Scott is the conference CME coordinator for an annual meeting, and he's got a great event lined up. Can't wait to see you guys there, and if you haven't signed up, spaces are growing quickly, so please do so as soon as you can. Information and details are on the paos.org website, as well as several social media outlets. Okay, for today's case study, we have a 13-year-old right-hand dominant female who presented to the clinic grasping her right forearm. She told me that she was walking behind her horse, and the horse unexpectedly kicked at a horsefly and directly whacked her forearm. She had immediate pain and loss of motion of the elbow and wrist and said her arm looked funny. She denies any tingling in the fingers, but she states that her pinky finger is quite numb. Her mom states that she has no significant past medical history and no known allergies. So I took a look at the arm, and she has an obviously angled proximal diaphysis ulna fracture with a large elbow effusion. There is, however, no sign of skin or loss of skin integrity. There are early signs of ecchymosis in various areas of the forearm and elbow. She refuses to move the elbow and has significant wrist decreased motion as well. Overall, her distal neurovascular function is intact except her subjective numbness in the small finger. She is able to wiggle all of the digits and feels pinprick sensations. So we got some films, and we see a comminuted angulated fracture of the proximal third of the ulna and a 100% radiocapitellar dislocation. So based on these x-ray findings as well as her history, what do you think is the most accurate diagnosis? Option A nightstick fracture with elbow dislocation. B, a Galeazzi fracture. C, a Salter 5 proximal ulnar fracture. Or D, a Monteggia fracture dislocation. So the correct answer is she has a Monteggia fracture, which is classified as a proximal ulnar diaphysis fracture with radiocapitellar dislocation. She also has evidence of ulnar nerve injury, but it's difficult to know the exact cause or the extent. The numbness could just be a neuropraxia, or she may have the ulnar nerve or branches entrapped in the fracture, or with the dislocation. There are a lot of things that could be going on here, so that's some concern. Now, the treatment for this is obvious that it needs to be reduced. I'm really concerned about the ulnar nerve. According to literature I reviewed on this, the reduction of the ulnar fracture will typically reduce the radiocarpal dislocation, but this needs to be completed where the patient can have sedation. I would think about reducing this in clinic, but when I'm by myself with little control of external factors as well as ulnar nerve injury, I think this really needs to be done under the bright lights with the patient having sedation or general anesthesia. I did put this patient in a long arm splint, and I did thorough neurovascular checks both before and after the splint placement. I did not try to reduce this, which again, with potential nerve injury, I think it's important to recognize that and to make sure that you give this patient the right treatment. From what I read when reducing this, I have to admit I have not reduced a Monteggia fracture. However, I've reduced a lot of fractures in the forearm before. But typically with simple traction, which reduces the fracture, it more likely than not will reduce the radiocapitellar dislocation. That is, if the annular ligament doesn't obstruct it. So again, document your neurovascular checks pre and post splinting. Get in touch with your on-call doc, which I did with this. The patient went home that night and had ORAF the next morning, and she's done fine. She did have a neuropraxia. The exploration of the fracture did not show any entrapment of the nerve, and the numbness went away with time. I did see her once, I think, in follow-up, and she was already back to working with her horse, and at this point she's riding and having a grand time with her horse and enjoying life with her arm with no problems. Okay, that's all I've got, and I hope to see you guys in Las Vegas. We're really looking forward to a big meeting, and we've got a lot of good stuff going, so please check out our website and check your social media for details. Okay, thanks a lot, and we'll be back next week.